Welcome to the Triage Method podcast with me, Gary McGowan, and my co-host, Mr. Patrick Farrell. Paddy, how are you this week?
As per usual, Gary, I am absolutely fantastic. It is a fantastic time to be alive. We're still stuck indoors, but supposedly, maybe soon enough, we'll be allowed out of our own homes. Although they did pause. This is obviously recorded. I don't know what date it is, but it's a Sunday, and I think it's not going to come out until next week. But as of today, they paused that AstraZeneca vaccination because of like blood clot issues or potential issues there that they're investigating, which is obviously not great because we've already had a fucking terrible rollout of vaccines in Ireland, and anything that even just presents a mild stumbling block, I don't enjoy that, because even if it's just, it's 2 weeks delayed, that's 2 weeks of my freedom potentially delayed, even though, that's potentially a good thing in certain regards in terms of, safer society, etc. But ultimately, like, I want to actually be able to leave my house more frequently than I currently do. And any impediment to that is, not beneficial to my life.
Yes, sir. We hope
And
for
yourself,
freedom.
Gary, you are still on placement as of now, or are you finished it now?
I'm finished now, back online for the next 2 weeks. We will have some virtual hospital tutorials. So that'll be interesting. And it's 6 weeks until exam time. And then I have one more elective prior to summer. And then there'll be time for exclusive triage work for a couple of months. So that'll be fun. In the meantime, just training away, studying away, working away, and happy out.
Phenomenal. And as you just alluded to there, we'll say, like, you are actually studying to be a doctor, right? And that is great because that clearly relates to what we're actually discussing in this podcast, which is, do doctors get enough nutrition education? I suppose we'll put it under that broad question, even though, like, what is enough? Like, that's a much broader question overall. Like, I know the two of us, from our perspective, we would love if, children were getting nutrition education, like in primary schools, throughout their entire education. I'm like, why are we singling out doctors? Because in our view, at least I would think, we would like everyone to be nutritionally educated, not just doctors. Now obviously, again, you look at like who has potentially the most impact on health and whatever we call this stuff, health, fitness, whatever. Like, it's going to be doctors, it's going to be those medical professionals, etc. So maybe, focusing on them first would be a great step. However, is that really their job? And that's something that we'll kind of touch on a little bit more as we get through this podcast. But the reason we're doing this episode in the obesity series is because this is, I'm going to say, an accusation that is leveled at the medical professionals, frequently, right? In terms of right now, like, some of the biggest leading causes of death in the world are, let's call them, like, non-communicable diseases that have a huge nutrition and lifestyle component to them. I don't think that is necessarily up for debate. It's like, if obesity, we know it's a calories in, calories out story. Now, obviously, that's incredibly, not nuanced, and we've been doing an entire podcast series on that topic. But fundamentally, that's what's going on. There is a mismatch between calories in and a mismatch between calories out, right? So we know that obviously has to have a huge lifestyle and nutrition element to it. And as a result, if we are going to tell people that are overweight and obese to, seek help as needed, in trying to get better their health, like, who do they turn to? One of the people they're going to turn to is their doctors, right? So if we know that these are issues that are, present in terms of, people's health, and we know it's a leading cause of death, and we know there's a nutrition component, surely doctors should know more about nutrition, right? And that's what we'll get into that, right? Like, if doctors are treating these conditions, like, they should know a huge amount about training, lifestyle, nutrition, right? You would presume, right? Or you would make an argument for, and that's an understandable, like, logical argument to make, right? And I'm just going to rattle out some things that I was reading up on just prior to this, because obviously I was investigating whether, these kind of, we'll call them accusations, are worthy, or are they actually worthy of investigation? Are they actually accurate? And some of the things I came across, now again, I haven't cross-checked, triple-checked the validity of all of this, and again, like, you can find conflicting numbers wherever. It's not like I'm going to these colleges. It's not like I emailed the deans of medicine or whatever being like, oh, tell me about your program or whatever. But most recent surveys show nutrition education time for doctors in America. Now, a lot of the data is from America because they keep usually better data than elsewhere. And also there's I'm going to say a bigger health crisis over there in terms of overweight and obesity. And this is the context of what I'm looking at this through, or the lens of which I'm looking at this through. But yeah, the education time for doctors in America is actually reducing, not increasing, which is a little bit converse to what you would ideally think, or you would like to see happen, if we're saying that, the non-communicable diseases that have a nutrition lifestyle component, they're actually increasing. The deaths from them are actually increasing. So surely if that's becoming a bigger issue, you would expect doctors to be getting more education on that, right? Further to that, only 1/5 of American medical schools require students take a nutrition course, right? So they're not actually required to do a nutrition course, right? Most medical schools, if I can't even speak, I literally said that. I was talking to Gary before this podcast, and I said that exact same thing, and I've never said that before in my life. But schools, anyway, is the word. Most medical schools in the US teach less than 25 hours of nutrition over 4 years, right? So you read those things, that can be very frightening in terms of, you're like, okay, wow, this is something that we should definitely address. These doctors are actually getting less medical education. And maybe you'll be able to touch on this in a second, Gary, when I allow you to speak. But you had to do a GAMSAT before you got into medical school, didn't you?
Yep.
And as far as I'm aware, there's not actually a huge nutrition component on that at all, is there?
Absolutely nothing.
So you have to do physics and stuff.
Yeah.
So
it's biology, chemistry, literature, everything.
Yeah, that's a bit weird. Again, just thinking of it from a logical perspective, surely you would want not necessarily to know physics, even though I would argue that you would ideally like to know physics. But you don't necessarily need to use that, but you're going to likely need to use nutrition information. So surely that should be emphasized even in the entrance criteria. But anyway, look, I digress. And they're all accusations, we'll say, that are levied against the medical sphere. And, again, you could argue very logically that this is something that we need to address. However, we also have to take it from a different perspective in terms of doctors are part of a multidisciplinary team in general, right? Now, maybe obviously if your doctor is, a GP, it's just your general practice somewhere and you're in the middle of the fucking country, I don't know, and it's the only doctor around for a couple of miles, maybe that doctor needs to be more educated in certain things, because they're the only source of information. But in general, most doctors are part of a multidisciplinary team, and this is especially the case, obviously, if you're in a hospital setting, especially a well-equipped hospital, right? And if we're going to say that doctors are the ones that are supposed to know about nutrition, are we just getting rid of dietetics? Are we just getting rid of the role of nutritionists? Where is the crossover? How much of which should they know? When do we start, stepping on other fields' toes, right? Should doctors even be giving nutrition advice at all? And I look at it from the perspective of me. I'm not going to give you surgery advice. I'm a personal trainer, a coach. I'm not going to be giving you surgery advice. Now, I might have opinions based on my my knowledge of biomechanics, the way that this individual's body moves, etc. But ultimately, it's going to come down to what your surgeon thinks is the best treatment for you, right? So why would you treat a doctor differently? If a doctor is there to give you kind of generalized advice, we'll just say GP, kind of generalized advice, get some tests, or the ability to refer you off to a specialist, why are you expecting them to know nutrition if their job is literally I'm basically going to, we'll say, diagnose the issue and then refer you to a specialist? If they've diagnosed the issue as you need nutrition advice, the specialist is a dietitian. Why are you expecting the doctor to give you the medical or the nutrition advice, right? They're there to give you medical advice. right? So again, like that's something we need to think through, right? And then obviously, like people kind of treat doctors as if it's a homogenous class, right? In terms of it's like, oh, you're a doctor. Like that means literally like fuck all, right? You could literally, and you see all these memes as well, like online where it's like, oh, I'm a doctor, and they're like, oh, this person needs help, and they're like, oh, I'm a doctor of like philosophy, or something that's not actually like a medical doctor like that we would refer to as a doctor in society, right? Like an MD in America, or I don't know what the term is in Ireland in terms of the credentials you get. I know it's a bit long.
BCHBAO.
Yeah, like no one's saying that. But anyway, look, there's obviously, it's not a homogenous class. Like there's a difference between the GP versus like a heart doctor, like a cardiologist type thing, or like a surgeon. Like there's clearly a difference here in terms of, yeah, they might all be a doctor, but their level of knowledge in a different field is going to be different, or it's going to be required to be different based on what they're actually doing day to day, right? Like they don't all need the same knowledge, right? And ultimately, I'm going to let Gary start speaking now in 1 second. Ultimately, the question that we want to answer today is like, is expecting your doctor to know about nutrition expecting too much? Like should they basically just treat it as, oh, I should just refer out for this? Should you go to your doctor for nutrition advice? What are your thoughts, Gary?
Yeah. So firstly, I think there's a case to be made here for trying to be conservative in your approach to the problem. And what I mean by that is that the conservative might say, okay, we've got all these grand ideas about how we could improve this, but maybe there's a reason that it is the way it is. Maybe there's something that we might be missing. And I think you can understand that better if you take a deeper dive into what it actually means to study medicine. And when you study medicine, fundamentally what you're doing is you're getting an introduction to such a broad field or fields. Okay. So when you say doctor, like that makes sense to the lay person. Like it's like, oh yeah, my doctor. You probably picture your GP realistically, or one of the doctors you might have seen in the hospital. But what that means to someone that studies medicine, or that is a medical or surgical doctor themselves, it means basically nothing, okay? Because if you graduate as a doctor, it's like, oh yeah, you're an intern, like you're bottom of the ladder, like you've basically no knowledge. We'll trust you to do some phone calls and to, you'll be making some decisions, but you fundamentally don't have a deep knowledge of anything really. What you've gotten is an introduction to a broad range of fields. So when you think about medical education, what you have to realize is that the education itself is very much an introduction that is going to give you a platform on which you can then build depending on your personal interest or field of interest. And that might sound like, oh, wow, I wasn't expecting that. Medicine is just an introduction, the degree, this hard degree that everyone talks about. And it's just important to understand both the breadth and the depth of medicine, because you've got to study so many different subjects to varying levels of importance. So, for example, anatomy, physiology, biochemistry, pharmacology, pathology, they're kind of core subjects that are important for basically any medical doctor. But if you want to then be, for example, a radiologist or an anesthesiologist, there's going to be more physics in those professions that you're going to have to dig into. Like an anesthesiologist is going to know lots about respiratory physiology and the physics related to that. The radiologist has to understand things like MRI and CT and the physics behind those things, because that informs how you interpret images. And they're like much deeper fields of study. Like the neurosurgeon or the neurologist is going to know the brain in such great detail. They're going to know all of the pathologies of the brain in far more detail than would ever be covered in medical school. Because what you have to realize is that when we get lectures, particularly in your early years, in your introductory years, when you get lectures on, let's say, diseases of the cardiovascular system, you might get a couple of lectures on that. So a couple of hours of teaching, but you have 2,000-page textbooks written on diseases of the cardiovascular system, all of the nuances of those diseases, all of the atypical presentations, different types of infections, potentially tumors, lifestyle-related diseases like we're discussing. So it's so broad and so deep. And it's absolutely just impossible to cover everything in a degree. Okay. It's just not how it works. And that's the reason why when you go to your hospital, for example, if you've got a chest infection, for example, like a very basic lower respiratory tract infection, most doctors are going to know how to approach that. You know, if someone comes in with a cough, it's like, okay, I have a rough idea for a diagnosis there. That's fine. You know, no problem. Someone comes in with a sore knee to the GP. It's like, okay, we're going to rule out some things, and they're not very complicated problems, or at least they mightn't be complicated problems. However, you've got a specialist or multiple specialists in each respective discipline that are going to have more niche knowledge. So for example, an oncologist is going to know so much more detail about the different cancers that could present and the treatments for those. And you might have like an ophthalmologist, a doctor who specializes in the eyes, who knows little to nothing about the different types of cancers that might present in, I don't know, the liver, for example. Like, yeah, they might have heard some stuff in medical school, but in terms of how you diagnose it and how you treat it, they're complex things. They're really complex things. So the overall point there is that as you come out of medical school and you graduate, there's all these different pathways that you can take. So for example, in your early years, you might decide, do I want to do medicine or do I want to do surgery? Like that might be a basic decision for someone. And those respective pathways then diverge further and further over time, to the point where, you know, a surgical trainee is going to be, you know, primarily interested in learning about surgical skills, for example, and maybe the basic like pre-op and post-op medical management, but they're not going to know about all of the medical management, even within the same respective system. So if you have a cardiologist and then you have a cardiothoracic surgeon, they're both experts in their respective areas related to the heart and the cardiovascular system, but they're going to have totally different levels of knowledge when it comes to the specifics. So the important thing to get there is that even when you get to these specialties of, oh, now I'm a doctor who specializes in the heart, it's like, oh, but what do you actually mean? Like, are you cardiothoracics? Are you, you know, cardiology? Or are you a pediatric cardiologist? Like, again, more complex. Like, that's another thing, is that you can subdivide this infinitely. Like, you could be someone who specializes just in pediatrics, or you could specialize literally in one organ or one type of surgery. Like, you might be someone who you're so specialized now that all you do is liver surgery. That's all you do. And it might be a particular type of liver surgery. So the overall point here is that medicine has infinite opportunities for specializing. The more you specialize, the more knowledge you accumulate. And the other important thing here is that within medicine and healthcare generally, you would almost always expect that disease would be managed in a multidisciplinary manner, as appropriate, of course. So I say as appropriate because the different members of that multidisciplinary team, or MDT, is going to vary depending on the particular disease. So for example, if you think about dietetics, because it's relevant to this conversation, people might think of a dietitian and they hear the word diet and they're like, okay, we're going to be talking about nutrition. So weight loss, how to generally be healthier, etc. But that's kind of not the reality. You know, a dietitian is very much involved in a medical setting with, for example, total parenteral feeding, nasogastric feeding, different ways of feeding people who are quite ill. You know, how do we create the right solutions? What minerals do we need to include? The person isn't eating, like all of these sorts of things. And then there's further complexity with the dietitian wants to have their nutrition plan of action implemented for this particular patient, but now that dietitian wants to know, okay, how are things on the medical side? You know, what medications are they taking? What's their fluid in, their fluid out? All these sorts of details. And then nursing might be informing those types of things. What's the urine output? What's the patient's weight this morning? Have they been eating when you've been walking past the ward? And then all that in mind, you've implemented all that, and now you've got to speak to the speech and language therapist because, oh, this patient actually had some difficulty with swallowing, so we might need to change the consistency of the diet. So all of this is just talking about implementing nutrition in a medical setting. And suddenly we've gone from dietetics to nursing to medicine to speech and language therapy. And then, oh, this patient actually is also having difficulty with holding the fork because they've had a stroke. So now occupational therapy is involved. Oh, and now the patient is having difficulty in the kitchen. So now physiotherapy is involved to try to improve their function, et cetera, et cetera. You kind of see where I'm going with this. The point is that medicine and healthcare is really complicated. and complex, and you have to have multiple different disciplines to be able to manage these problems, because there's no one discipline that can do it. So even when you break it down to the field of dietetics, for example, you might have dietitians who specialize just in patients with kidney disease, or just in patients with cardiovascular disease, or just in patients with malnutrition. Like, that might be their respective area of expertise. And that just goes to show that even as you break it down to the level of just saying nutrition, that can mean many different things. You know, are you talking about this kind of general lifestyle related stuff that we talk about as it relates to the fitness industry, let's say? Or are we talking about how to maintain nutrient status in a patient who's had some sort of surgery that removes a certain part of the bowel? Okay, you need to know then the actual anatomy of the bowel and what nutrients are taken up in different areas, and then how that nutrient uptake might be affected now that that person has had that surgery. So things become very, very nuanced, very, very quick. And if you were to speak to a nutritionist, or someone who might make this argument, the doctors should know more about nutrition, they mightn't even know that much about nutrition, because if a patient has had a colostomy, you know, they've got this, they've had surgery and they've got, let's say, a stoma bag now, they don't know the nutrition indications for that. They don't know how to manage that. And you wouldn't expect them to, you know, why would you? Like, and the point there is that everyone has their own respective field of expertise. And because medicine is so deep and so broad also, I think that the calls for doctors to have very high levels of nutrition education within medical school is really, really difficult. Because the thing is, like, it would be great if doctors could have, you know, 100 hours allocated to comprehensive nutrition education. But then also we'd like them to have that education in psychology and behavior change, for example, because that's important for implementing nutrition, but also for implementing medical interventions. And then we might want to know, for example, exercise as well. You know, you need that education for exercise as well if we're making the case for nutrition. And then we might need to know even more complex things, like, for example, some people will make the case that, oh, doctors need to be addressing racism, or doctors need to be addressing social inequalities, or doctors need to be addressing housing issues. All of these sorts of problems that can absolutely affect someone's health. But how much of a role do you want the doctor to play? You know, do you want them to actually know about the best option from a medical management perspective and how to implement that, and then refer out when it goes beyond that? Or do you want them to maybe sacrifice some of the knowledge of their anatomy, let's say, to spend it on understanding exercise to a deep level, instead of referring to physiotherapy, or instead of referring to personal training? So they'd be some of the initial defenses that I think are important to keep in mind. But there is also another layer to this, because we could actually make the case that, you know, there's lots of improvements to be made. And what would actually be fantastic would be, yeah, doctors do have, you know, some basic level of nutrition knowledge, but that they also have systems in place to refer to, let's say, community dietitians who specialize just in prevention, for example, or community physiotherapists, or community personal trainers or strength coaches that are within, let's say, the HSE in Ireland, that we refer out to, and we've got this lovely network going. That's an ideal world, and that's very difficult to implement. And this is where you have to consider trade-offs, for example, because very often people who are interested in healthcare will advocate for things like socialized medicine, for example, or some sort of social programs as it relates to healthcare. And then that just brings you to the next question of, okay, how are we going to allocate funding? You know, what's more important? For example, some of the medications for cystic fibrosis, or Cambi, I believe is the name of it, I think it can cost up to €400,000 per year. And it's like, okay, that's for a single patient. How do we weigh up the ethics of allocating funding to that particular cost versus a €400,000 lifestyle intervention within the Dublin region, let's say? These are very difficult things, and they're the types of things that present challenges in healthcare, because how do you manage all this? You know, it's like the fundamental problem of central planning in economies generally that's applied to healthcare. How do we make the decisions? What areas are we going to optimize? And where are we going to get all this money? You know, are you willing to pay like 70% taxes to fund all these new lifestyle programs? This is the difficult thing. So I absolutely think that there could be improvements made for sure, and particularly, for example, for diseases like diabetes, cardiovascular disease, all these diseases that we consider to be very much related to lifestyle, and that lifestyle is very much involved in the management. It would be great if we had better programs for within the community, like outside the hospital, for prevention and for secondary prevention. But there's just many layers of problems that make that challenging. And I think that expecting the overworked junior doctors on the floor to be able to manage this is really challenging. And outside the hospital, from a GP perspective, again, we run into the same problems, because depending on where you go, whether it's Ireland or the UK or America, the GP consultations can be as short as 5 to 10 minutes. And very often that involves like screening for ensuring that, let's say, this isn't a more serious problem that requires referral. The patient might have multiple problems they're presenting with. They might need medication review, subsequent prescription, etc. And it's just very difficult to fit everything involved in health within those brief consultations. And that's fundamentally not modifiable unless we have some sort of healthcare reform, like, okay, we've triple our number of GPs, and millions and millions is allocated to funding. Like, they're difficult problems, man, and I don't know how to solve them.
And this is one of those things where it's like, how do you allocate resources that have alternate use? Alternate uses, like who gets to decide that? Like, say we do have like some sort of, like, again, we'll call it socialized medicine, even though, like, technically in Ireland we do have socialized medicine. Technically in Ireland right now we don't have private medicine, but that's another story, right? We have socialized medicine, right? But even if that's the case, and we say we have that in Ireland, like, right now people are making these same arguments. Like, that's not necessarily going to solve it, because even with the confines of the resources that they have, they obviously are like, okay, well, I don't want to allocate these resources to this issue because they're not seeing it as a beneficial strategy, right? They're like, we can actually impact more change, impact more lives by allocating those resources elsewhere. And that might not be the case with the disease that you care about, in terms of, like you use the cystic fibrosis one. Like, if you have cystic fibrosis, or, God forbid your child has cystic fibrosis or something, and you're like, oh, I would rather have all of the money allocated towards this. Like, that's always going to be the case. And then it just becomes like this moral and ethical dilemma. And, like, obviously it's political or quasi-political as well layered on top of that. And it's like, this can just be stuck in a quagmire then, because no one wants to move an inch, because their issue is the most pressing in their lives, and potentially they can't see it from another perspective as a result, right? But then also, you don't want to just like wash your hands of this. You're not like Pontius Pilate or something and be like, right, oh, look, the system is what the system is, so let's not even try to look at it. Let's not even try to change it. And I don't think that's necessarily a beneficial strategy either, right? And it basically comes back to this thing where it's like, okay, like, how much nutritional education does someone actually need, right? And I'm going to ask in terms of a few, or I'm going to suggest in terms of a few different fields of doctors. Like, as we said, like, a doctor is not a homogenous group, right? There's obviously going to be a few different types of doctor, we'll say, that require more or less nutritional education. And as you said, that doesn't necessarily need to occur at the 4 to 5 years that you do to become a doctor. Like, that's the entry level stuff. That's not necessarily the time to be learning this stuff. However, after that, you would expect a few different types of doctors to have that knowledge. However, before we even get onto that, let's look back and go, I said earlier on that they get, teach less than 25 hours of nutrition over 4 years, right? 25 hours is actually a fucking long time.
That's decent.
Like, that's actually a lot. Like, realistically, if you got me someone in front of me that was, educated enough to get in to do medicine, right? So they're obviously intelligent, and they can obviously, well, even if it's just a case of like, they can memorize things, they can, memorize the nutrition stuff just as easily as they can memorize the anatomy or the physiology or whatever. Like, they're an educated population. It's not like these people are stupid, it's not like they aren't able to pick up the information. Like, how much time do you actually need to educate someone on good nutrition practices, right? Like, realistically, I was thinking of it and I was like, man, you could get someone to have a really good understanding of nutrition in probably 3 hours. Like, think about it. You spend an hour on, especially from from a doctor's perspective, because it's very similar to from a coach's perspective, right? obviously with major differences, but hear me out, right? So the first thing is like, you need to teach them like calories and macros. Like that's the foundation of a diet. If they understand that, they've got such a good grounding overall that, you know, the layering on top of that, you know, it's kind of less relevant, right? So we'll just go calories and macros. You can teach them all the finite stuff you need to know in that stuff in an hour, right? Not obviously not all of it, but you know what I mean? Like a fairly decent understanding in an hour. You know, we'll talk about the upper and lower limits. Now, for a doctor, you know, maybe you want to layer on some micronutrient stuff as well. But again, we'll just even say that's the role of a dietitian to look at that stuff, right? We'll just, you know, put that out there, right? Then the next lesson, you know, what do you need to teach? You need to teach how to actually implement that in a real diet, right? How do you actually like hit these targets? Okay, you know about protein, but well, what the fuck is protein? Like, how do I get, where do I find that in my diet as a normal person, you know? Like, so you need to actually think about the actual foods, right? So the first lesson, it's all about the underlying nutritional science. The next lesson, it's all about like the implementation of that. And again, you could do that fairly quickly, you know, and again, this is why they have stuff for like generalized health recommendations where it's like, here's the food pyramid. It's because it's quick and easy, you know, it's not because it's perfect. It's because I can disseminate a lot of information very fucking quickly with just, here's how it should look. And I think as well, especially since they've moved to like my plate rather than the nutrition pyramid, I'm like, that's actually a really handy way of teaching this stuff to both the patient and to the doctor, you know? And so we'll just say you spend an entire hour going on top of that, right? And we'll assume like, you know, the doctor is going to spend some time outside of this doing a bit of extra learning. Let's say, you know, I know in college, they always say like, oh, this 1 hour of lecture time is like 8 hours of, you know, study time yourself. I'm like, what the fuck am I studying? Like, you know, this was fairly intuitive. But anyway, look, let's just say you do that the second hour. Then the third hour, it's like, how do you actually coach this stuff? What are the issues you're going to run into? What are the objections? What are the different things? Like, what you can even touch on, like the socioeconomics. You can even touch on the, you know, like whatever it is that needs to be layered on top of that. 3 hours, you could build someone's nutritional education, an educated person's nutritional education to a phenomenal standpoint. You know, so if they're getting 25 hours, you know, like that's fairly decent. Like, how much more do they actually need?
Yeah, I don't know where people are getting 25 hours of nutrition education, to be honest. Like, that's pretty, like that would be absolutely pretty decent. But even if you took all that knowledge on board, like it's still so difficult to implement. Like that's the fundamental problem here, is that like I think there's a huge disconnect between like the personal training world and like the realities of healthcare. Like, you know, even in terms of like health literacy and the challenges of like buying certain foods, or the role of like someone's individual like culture and family in shaping their diet. Like all these things are so challenging, and as personal trainers, the problem is we actually get people at their point of preparedness where they've decided, I want to change my diet. And if they come to Triage, let's say, you've been following Triage, you've listened to the podcast, you're clearly someone interested in all this. And now you're saying, I am ready to implement these things. But if someone's in hospital and they're sick, they might have been fine a couple of days ago living their life, and suddenly they're in the depths, like they're at their worst. Like now is not necessarily the time that they're thinking, oh, time to change my diet. Like certainly that happens for some people. Like my grandfather, when he was only 60, I think he had a massive heart attack. And from then on, boom, all right, I'm never smoked again, you know, doesn't drink, eats really well, because that was enough of a shock to the system. But the challenging thing there as well is that because when we talk about non-communicable disease like diabetes or cardiovascular disease, for example, these are chronic problems. So by the time someone ends up presenting, let's say with, I don't know, a diabetic foot ulcer, let's say, or problems with their vision, things have already progressed. Like there's so much of behavior development, habit development, dietary preferences, etc., and the, you know, adoption of a certain lifestyle and the complications of the disease. There's so many things that have happened to get that person to that point that it's really difficult to elicit change. And the later in someone's life that is, like, again, you can see how there might be different challenges. So these are all the things you do have to keep in mind. Like obviously the ideal is that there's sufficient resources and low levels of inequality, and there's education in schools and everything, that all of that is prevented because all of this is implemented early on. But when it comes to the kind of reactive approach of someone now being in the hospital and now their doctor is going to give them nutrition education, like that's just super difficult to implement. It's kind of the same thing that we talk about when, you know, people will take pictures of hospital food, for example, and say, oh, this isn't healthy, I was in hospital, how am I eating this? Again, it's like a question of, all right, you know, remember the last time you were sick? Like, did you want to have chicken and broccoli when you were sick, or were you just like, oh yeah, you know, I can get in some toast, I can get in some cereal? Like, these are the realities that you have to be thinking about. And unfortunately, it's just not easy to get people to change their behavior. And I think as personal trainers, you also know that, you know, you've probably had periods of time, I know it's happened to me, where you'll be giving someone advice without them necessarily being at the point where they're ready for it. Like even a family member or something, you're telling them, oh, you should change your diet. Look at what you're doing. Your health is bad. You know, you're overweight. You should start changing your diet. But because you're coming at them and you're telling them all this stuff, they're not going to change their diet because of that. And that's similar to when people present into a hospital when they're now sick. They weren't ready for this. Like they didn't decide, oh, I'm going to actually pay Cork University Hospital €1,500 for 90 days. And I'm going to get my treatment plan. So I think there are some of the realities that maybe don't shine through all the time.
Yeah, it's just a hard situation overall, like both from the client perspective, well, I say client, the patient perspective, who's looking for more information because they're like, oh, well, I don't want to have to go to some dietitian, or I don't want to have to go to someone else to look after my nutrition. And they just want to get, oh, here's my GP, they'll tell me what to do. But then also from the GP's perspective, they're like, man, I have people coming in here with so many fucking different issues. I'm like, I can't keep up to date with all of the latest nutritional science as well. You know, it's like I have other more pressing, you know, issues that are potentially more immediately fatal or immediately, I don't know, mortal, I suppose. And there's more, you know, there's an issue here right now. You know, it's like it's going to cause an issue in the next week, day, month, whatever it is, versus, oh, this person needs help with their nutrition, and that's the actual intervention they need. Potentially, they're looking for that help. Maybe they're not at this time, like you were saying, but that's not going to become an issue for the next 20, 30, 40, 50 years. So you're like, I can kind of put that by the wayside for now, and I can focus on little Timmy who broke his leg, or, you know, someone who has, I don't know, super high cholesterol right now, and it's like, okay, we need to get you on statins because you're probably going to have a heart attack soon. You know, it's like there's only so much that a doctor can actually reasonably be expected to do. And like, I think both of us would be an advocate for, like, you know, a multidisciplinary team in like an actual like GP practice, say, for example, you know, like let's say you just have, like, I don't know, you'd have to do the numbers, but let's just say you have 5 doctors, 5 physiotherapists, and 5 dietitians in that facility, you know? So it's literally just a case of like, oh, this facility is just taking care of you and the general population entirely. It's like, okay, you get the doctor is there, and then also you have your diet and lifestyle stuff, and then you also have your like physical stuff, you know? And like that's the kind of stuff that we look at. We're like, okay, health, training, nutrition, and lifestyle. So it's like, that's obviously what we would like to see. However, it's like, well, then maybe you add a psychologist to that, you know? Maybe you add I don't know, a childhood physiotherapist. You're like, oh, we need to have one of those specifically. And maybe you add, I don't know, fucking, you can keep going adding people. It's like, okay, we actually see that there's a higher prevalence of, you know, this disease in this population, so we need to add this. But then it's like, okay, well, we've added that, what's the next highest? You know, and it's like, oh, we'll add that. And it's like, what's the next highest? You know, you just keep adding to the team, which is great if you're a hospital. It's like, you want to have all the fucking specialists, you want to have all of the options possible to you, you know? And obviously that's the case in, like, we'll say bigger hospitals, and they have specialists for everything, you know? Like if you go to a hospital in, I don't know, some mega city, like, I don't know, LA or New York or something, it's like they're going to have, you know, a doctor for the most minuscule, potentially in a normal population, a normal, like, you know, worldwide thing. It's like, oh, they would do 1 surgery per fucking year. but it's because they have such a high population density. It's like, oh no, they're actually getting one surgery per fucking week here because there's so many, you know? And obviously that's the case in Ireland, especially, where it's like, you know, we're a relatively smaller nation. You know, how many people do we have in Ireland? 6 million or something, you know?
4.8, I think.
Yeah, like very, very small population overall. Like there's literally cities with higher populations, you know? And so like, imagine in this, I don't know, we'll say the size of Dublin, all of that population was there, plus another fucking 11 million or something, you know? It's like, there's obviously higher opportunity for just a facility like what we're talking about in terms of having this multidisciplinary team in that actual facility, because they're going to be able to go, okay, we can see more people. Whereas again, like if you're a GP practice in the middle of fucking, I don't know, Connemara somewhere, that's, you know, there's literally fucking 20 houses around you for fucking 10 miles. It's like, there's less need for, well, there's probably more need for a multidisciplinary team, but there's less opportunity to have that as a result of the like low population density. And in those cases, yeah, you could argue that the GP needs to know more about nutrition. But if you're a GP in, again, a high population density area, you know, I can just refer out. You're like, I know 10 other nutritionists, dietitians, whatever, that could help in this case. But that isn't necessarily always what the patient wants, you know, and especially it's not always what the patient is ready to receive, as you were stating there. So like, it's a very hard situation overall. And I'd love to say at the end of this podcast, we had just some quick and easy fix, being like, yes, this is how we solved the issue for the society. And this is how you get the best service for you as a, you know, person looking to get better health management overall for whatever disease you have. And obviously we're in this like obesity, overweight, podcast series, so like we're talking from that perspective. But even in that case, it's like there literally is doctors that are specific, like obesity specialists, you know? So it's like, if you're going to your GP and expecting them to be able to cure or help you in its entirety your overweight, obesity related diseases, it's like there's a specialist for that. That's like going to your GP and expecting them to fix your heart condition in its entirety without ever seeing a heart specialist. I'm like, how is it any different? You know, there is a specialist for this. I know in America they have like lipidologists. I think that's the term, isn't it? But let's just call it like an obesity specialist. Like there's a specialist for that, you know? So you would expect that specialist then to have more information related to nutrition practices, lifestyle practices, even training practices for that condition. You know, like you wouldn't expect your GP to have all that knowledge, which I suppose brings us to the next point, is like, what doctors should have more nutrition education. Let's take it from going back to earlier in the podcast where you said that, you know, medicine in your 4 to 5 year degree, however long it is, like that's basically just entry level. Like here's all of the information you need to know at a surface level, even though obviously it is quite in depth. It's like, it's basically just surface level stuff, right? And then you go on to actually get your, we'll call it further education, and your quote unquote real education. What doctors, as a result of that real education, should have more nutrition knowledge? Because I can think of a few right here. I just wrote them down before the podcast. Like an obesity specialist, you would expect them to have a good grasp on, you know, basic nutrition stuff, you know, because that's pretty much, well, I say that's not necessarily true, but that's probably one of the most effective interventions for someone that has obesity, overweight related issues, right? Now, obviously, again, they are probably working as part of a multidisciplinary team. Like they probably have some sort of dietitian, some sort of nutritionist, but you would at least expect them to have a good, decent level understanding of nutrition. I don't think that's incorrect. Do you, Gary?
Oh, that sounds fair to me. Yeah, obesity specialist, you'd expect that there'd be some knowledge of nutrition there. And obviously that, like, there's some other big ones that jump out. Obviously, if you're a cardiologist and you're working with a lot of people who have atherosclerotic cardiovascular disease and related complications, nutrition obviously becomes very important there as well. So you'd expect that, you know, they would have more knowledge of the dietary factors that can lead to progression of disease or potentially the improvement of symptoms, etc. So that's obviously a big important one. Diabetes is another one.
Just before we go on from the cardiologist, like you would expect those, especially because even in the, like, it's not like you can get away with just prescribing someone a statin and no lifestyle diet changes, like that's still not going to quote unquote fix the issue. You know, like if you're literally, I don't know, 70% of your diet is like saturated fat, and then you go on a statin, that's not necessarily going to fix the issue that this person is having. So in that case, it's like, okay, well, we need to have the nutrition and lifestyle secured down pat for that individual, you know? So again, cardiologist, 100%. And as you were going on to diabetes then as well.
Yeah, and to be honest, like even when it comes to these specialists, like it's still not necessarily that they need to be like expert in nutrition related to these areas, but rather that you'd hope that there'd be enough knowledge that if there's a specific problem identified, they can identify it. Like you said, like if you're a cardiologist, you know, and you're let's say you're a busy junior doctor training in cardiology and you're seeing patients, like it might be like, oh, how's your diet? Could you tell me a bit about your diet? That they have enough knowledge to be able to say, oh, it looks like you're eating, you know, lots of fat in your diet. It looks like lots of this is saturated fat. You know, you're eating lots of processed foods, not many fruits and vegetables. I think you could do with some improvements. We have a dietitian that I could refer you to if you'd be up for that. You know, it's those types of things, rather than spending, you know, 2 hours of the day counseling someone and writing them a meal plan and stuff. Like, I think it's far beyond the resources at this point in time, other than some unique situations. But that's kind of the reality. And diabetes is obviously another big one, both type 1 and type 2 diabetes in this case. And again, there's different considerations. Like with type 1, you might be actually just being really careful about the management of diet as it relates to the medication itself. Whereas with type 2 diabetes, it might be that you're actually looking for potentially remission from the disease through dietary intervention, or again, just management of blood glucose, tracking it, etc. So you can see how there's even different goals, and you'd expect that while a doctor might be, you know, giving some rough information for a patient with diabetes and nutrition, they're still not going to be the one carrying out like an aggressive lifestyle intervention for the purpose of remission. That would be an MDT approach, and you can see that in the research that's been implemented for the remission of type 2 diabetes. Like, it is very much an intensive MDT approach, pretty much. So they're kind of real core areas that I think nutrition is obviously very important. And then it starts to get a little bit more niche, because, for example, in gastroenterology, like that has many different subcomponents to it. Like, for example, they could be dealing with diseases of the liver, the gallbladder, the colon, the rest of the intestines, etc., and the stomach, the esophagus, and all these different areas have different risk factors for different diseases, for example, whether that be esophageal cancer or bowel cancer or gallstones or whatever. There's different nutritional factors that can interact with each of those respective diseases. So again, it might be more niche depending on the specific disease. So there might be some level of nutrition knowledge there. For example, if a patient has had a certain bowel surgery, what nutrients might they need replaced or something like that. But again, that's kind of where dietitians start to come into the picture, really. But that depends. Like, this is the other thing, is that the scope of, let's say, a dietitian intervention might vary between sites. For example, if you've got a really high density of dietitians within the hospital, they can do far more. You know, they have more time to be able to counsel on these lifestyle related things. Whereas if you have less dietitians, then the priorities and the really high yield things are nutrition in acute illness. Okay, so preventing, let's say, malnutrition, or addressing malnutrition, and finding other strategies of feeding beyond just oral feeding. So again, it's all really resource dependent. There's obviously other areas of the body that are heavily affected by nutrition. Everything's heavily affected by nutrition. But for example, in elderly populations, super important, geriatrics, the identification of malnutrition, sarcopenia, frailty, etc. Particularly, let's say, if someone presents with osteoporotic fractures and they're really weak and they're struggling to carry out activities of daily living, nutrition intervention in that case would be really important. So an example of nutrition knowledge that might be relevant would be malnutrition screening, in that for a geriatrician, let's say, calculating MUST scores, the MUST, it's just screening for malnutrition. So you can even see that as we start to talk about nutrition that's important for doctors, or what doctors might need more nutrition knowledge, we've gone from the management of blood lipids to, let's say, the nutrient deficiencies that might be present after certain bowel surgeries, all the way to screening for malnutrition in elderly populations. So each respective doctor is going to have more nutrition knowledge, but again, it's in a particular area, and it's primarily, I think, for the purpose of liaising with a dietitian, unless you have, let's say, in the US in particular, you'll have, let's say, obesity physicians who have private clinics, you know, and they have so much time to spend with their patients, and, you know, they're really intensive with working with nutrition and everything like that. But within the HSE and hospitals in Ireland, like that's just not really the reality.
Yeah, there's a few other ones as well that I would like to mention. That is,
go ahead.
like an endocrinologist. I'm gonna put these all together, like endocrinologist, a urologist. I know that's what the American term is. I'm not sure what the Irish
urologist. Yeah,
urologist, and then like a gynecologist, and that kind of all seem like, why? Well, like, why would you want them to be nutritionally educated? And that's because obviously there is a huge nutrition component to hormone health in general, right? Like if you're looking at someone's blood, if I could speak, someone's blood panel, and you're like, oh, I don't know, for example, your SHBG is high. It's like, this has dietary reasons behind it. Or maybe you're looking at someone and they have like low testosterone, and like you could understand that, oh, you've actually been on a really calorie deprived diet, you've been doing a lot of like, cardiovascular exercise, and your sleep hasn't been great. That explains why this is low. We need to have some lifestyle interventions before we go on to something like, TRT or something, like you see, this is a big thing in the fitness industry, especially now, where people are basically like, oh, I'm on TRT, it's not steroids, and basically they just go into their doctor after having dieted down for, whatever, 16, 20 weeks, having like a week of like partying, shit night's sleep, and then they go in, their T level is fucking down at like 200, or they get fucking measured later in the day or something, and they're like, oh, look, I had an issue, and in reality, it's like, these are just diet and lifestyle related factors that could have been addressed to get that up. Now, that's not always the case, don't get me wrong, but like, obviously, again, if your doctor is able to identify those things and look at your diet and go, okay, this is actually, we need a dietary intervention to deal with this, rather than putting you on a lifetime of medication, like that's obviously something that you need to be aware of. And again, I say like a gynecologist in particular, because obviously they're used to, or they do indeed have to help with the management of fertility, usually more so than in males, right? And because obviously if a female can't get pregnant, like a woman can't get pregnant, like she's probably the one that's going to go in and get checked before the man goes in and gets checked, and even though, again, it could be like literally a 50-50 chance of either of them having an issue, but she is the one that's likely to go in and get checked and have interactions there. And again, there could literally be a lifestyle and diet quote unquote fix for the situation, like she might be, I don't know, amenorrheic because she trains really hard, doesn't eat enough, and does a load of cardio as well. Again, sleep has been poor, and like that's the issue, and again, a gynecologist is going to have to be the one that potentially deals with that. And then obviously, again, like in this broader category, especially as we move into the world of potentially more and more like IVF solutions and like fertility type stuff, like doctors in that field, we'll call them like fertility doctors, like they are going to have to be more aware of diet and lifestyle overall. And because obviously, again, like first of all, it impacts fertility, but then obviously if you are trying to get your client, your patient, to have a successful full-term pregnancy, like you're going to have to be able to support them nutritionally, make sure they're in good health overall for that. Now, again, they're probably going to refer out to a dietitian, have like an in-house dietitian. If you're going to some fertility clinic, they probably have that. But that is something to obviously be aware of if you are a doctor in that field. Like you would ideally like them to have a good understanding, or at least a basic understanding of the nutritional demands of that. And especially like, something like, I don't know, vitamin A, like it's teratogenic in the first, 6 weeks or something of a pregnancy, but it is also, you need to have sufficient vitamin A intake to be healthy and to be fertile in the first place, so like this kind of stuff, it's like you would expect a doctor that is dealing with that more often like again, a gynecologist perhaps, or like a fertility doctor in particular, you would ideally like them to know that stuff, rather than just giving you some generic recommendations, which are potentially, you know, harmful for you, you know? So other than that, the only other one that I would say is like you would expect, or you would, I'd say expect, you would want a GP to have a very broad, like I say broad, and that's the wrong word, a very superficial understanding of nutrition. Like they should know about calories and macros and what that looks like on a plate, you know? However, even in that case, like, especially if they are quite a busy GP, like oftentimes it's probably, first of all, more fruitful for them to refer out, but also oftentimes it's probably just as easy for them to have some, like, we'll call them like brochures or something, where it's like, this is, you know, in 2 pages, the basics of nutrition for the client. And rather than them spending 20 minutes that they just don't have because they go in for a 5-minute consultation, like, it's probably easier for them to be like, right, you actually need to, or they should say it differently, but, you know, you actually need to improve your diet. Here's the brochure that we use to help people with that. We can refer you out to X, Y, and Z if you need to. But let's see about these changes first of all, see what, you know, benefits we can get from that. So I would expect, or I'd want my GP to have some superficial knowledge, just, you know, the basics. But again, I understand why that potentially isn't necessarily possible, especially depending on the setup of that general practice.
Yep. I think that overall, what we've identified in this podcast is that there's just a big problem of trade-offs, a big problem of resource allocation, and also the problem of scope of practice within an increasingly complex world, and especially increasingly complex field of medicine. Because this is one of the challenges that basically exponentially increases with medical education, is that, like, if you take, let's say, like the management of any disease, let's say cancer, okay, if you were to go back 50 years in cancer, cancer treatment, there was basically like a handful of drugs, you know, a handful of kind of very blunt chemotherapeutic agents that just kind of were just really cytotoxic, and that was it. It's like, there's this handful of drugs, we're kind of trying them out, very much an experimental phase of cancer treatment for most of the 20th century. But
Just for anyone who's interested, that literally came from like chlorine gas. I believe it was the Americans that were actually hoarding chlorine gas. I want to say it was off the coast of Italy, but that doesn't make sense because it was in World War II. But somewhere anyway. And what they found is, like, once they basically had a ship sink, and those chlorine canisters fucking whatever exploded, whatever. And all these sailors that were subjected to that, all of a sudden, like, all of their rapidly dividing cells just, you know, didn't rapidly divide anymore. So they were like, this is interesting. We could use this for other rapidly dividing cells. So that's why they were blunt force. It's literally just fucking chlorine gas, the same stuff that was fucking, you know, in World War One.
Yeah, and there was a lot. There was a few drugs that basically were tried on their own, and then in cocktails, effectively, different combinations of drugs, trying to see like what could possibly work. But as the 20th century unfolded, then you have far more specific treatments as we head into the 21st century. So you've got very selective treatments down to the molecular level, like depending on the molecular signature of a particular cancer, like there's treatments that are very specific to that, and immunotherapies for cancer. And there's just so many different options that, like, medical education now is not the same as medical education 70 years ago, okay, or 100 years ago, or whatever. So, and that's going to basically continue increasing, and that goes into many different areas. Like, for example, another area that's rapidly developed and developing is interventional radiology. Okay, so lots of different procedures that can now be done through basically just the use of catheters and small cameras and all this sort of stuff. And as all these advances go forward, the problem of medical education is continually, what should we teach? What's most important? Because you can't just make it a 15-year degree, you know? So ultimately, like, specialties keep dividing into subspecialties, and it just takes more and more time and more effort to get into one of these subspecialties. So Like,
This is even further compounded. We have like this like genomic revolution.
yeah,
We start entering into this like precision medicine realm. Like I obviously have an interest in depression, and obviously you do as well. But like a paper came out recently, and it was just talking about they're at this kind of cusp of like understanding like SSRIs a little bit better in terms of how different populations, based on their genes, actually are likely to respond to different SSRIs. You know, like you see the common thing where people are like, "Oh, I tried this SSRI, it didn't work for me," or I didn't get any effect. And obviously, like that's really hard because there's this like latency period of the effect. It's like it takes 6 weeks plus for it to start to work. So you've effectively got this like a sunk cost fallacy as well, where it's like, oh, I've already been on this for 6 weeks and it hasn't worked, and you're like, should I just keep going, etc. But now they're in the stage, or they're getting into this stage where it's like we're able to identify the genes that could potentially lead to understanding which drugs to prescribe before we have to wait 6 weeks or 12 weeks or whatever. And it's like, that's just in that field that I know a little bit better. But that's across the board. Like we're in this kind of systems biology, precision nutrition, precision medicine realm, or at least we're getting to that. And like, I'm heavily invested in like genomic therapies, and CRISPR therapeutics is actually one that I'm, just in case anyone's looking for, some shout outs. But anyway, like genomic therapies, I'm like, this is actually such a, like we're at that stage where it's like, these are like gene sequencing has become so much cheaper that we can actually start implementing this on a mass scale. Now, right now, is it fucking viable? No, not really. Because we don't know enough. But because systems biology, which is just, basically overview picture of how biology works on all these different systems, we'll say, like that's advancing rapidly. And like I can easily see in the next 10, 15, 20 years, it being a case where you literally have to be extremely well knowledged in genetics, genomics, to be a doctor, and it's like, are they preparing doctors for that right now? I don't think so. But again, it's like, it's hard to say like, oh, let's prepare the doctors right now for that, when we might reach a bottleneck with that technology that we haven't, understood ahead of the time. And now you've just got a lot of doctors that think that genomics is going to be like the thing that they need to have. And then it's like, oh no, this is actually 20, 30, 40 years away. And, you've wasted 5 years of this education because it's not actually implementable technology, which again goes back to the first 5 years or the first 4 years. It's basically like, here's the fucking general stuff that doesn't really change, like obviously the protocols and that kind of stuff, that changes. But, how the liver works doesn't necessarily change. So you have to get a good understanding of that and then layer on the extra stuff once you actually start to specialize.
Yeah, so that's the expert opinion on medical education from a second-year medical student and Patrick.
An idiot.
But yeah, look, guys, as you can see,
we're solving world hunger next week.
But yeah, as you can see, look, I think if you've listened to this podcast, it'll be very clear that like deciding what goes into a medical curriculum is very challenging. And while the ideal, of course, is that doctors would know everything about nutrition and everything about exercise and everything about psychology, it's just not realistic, really, because first you have to know everything about medicine, which is basically impossible.
Lifelong endeavor already.
Like there's literally no doctor that could tell you everything about every field. Like it just doesn't happen. So to expect them to know everything about another field is ludicrous, ludicrous. So there you go. That's the problem not solved but discussed.
Yes. Overall, I think, look, if you're a doctor and you want to help more people, learning about nutrition is definitely a good thing. Like it's not going to not serve you, However, maybe it's not going to serve you as much as specializing your time or allocating your time on the stuff that actually pays the bills, is your bread and butter, is the stuff that you need to know for your specialization or whatever. However, I know the two of us are definitely advocates for more continuing education around exercise and nutrition. I'm not going to say I'm not going to recommend that. I'm like, yeah, look, if they can wiggle in some extra nutrition education to a medicine curriculum, happy days. I'm good. I'm good with that. Yep. Exercise as well, I'm good with that. Fantastic. However, ultimately, I want to go to my doctor I don't want to go, or rather, I don't want to go to my doctor to learn that stuff. I would rather go to my doctor when I actually need to go to my doctor because I'm sick or because I have an issue. I don't want to be like, oh, you spent the last 20 years learning about nutrition. Well, guess what? I spent the last 40 years learning about nutrition. So I don't need that intervention. I need help with my, I don't know, fucking inflamed prostate or something. I don't know, like that's, I would rather my doctor knew what doctors are supposed to know rather than what dietitians or nutritionists are supposed to know. But anyway, I have nothing else to say on the matter. Do you?
No, done.
Fantastic, Gary. Where can people find us?
Nowhere.
Oh, or we're just non-people anymore. We're just gone
in the dark.
Oh,
yeah, you can find us on social media as at Skinny Gaz. That's me. At The Real Paddy Farrell. That's Paddy. And at Brian O'Hengasa. That is Brian. We're all putting out content on our pages. It's all a bit different. So follow us all. And also follow Triage Method, of course, on the socials. Along with that, we do have coaching spaces available. So if you are interested in our coaching service, we'd be happy to work with you. Just reach out. You can drop us an email, info@triagemethod.com. You can go to triagemethod.com and look at the information there, or you can reach out to any of us individually via Instagram DMs, and we'll get back to you, give you more info. No problem at all. We do have a newsletter as well, which you can subscribe to at the link below, and a Facebook group, the Triage Method Community, which you can join for free. Ask us any questions in there that you might have. If you want to discuss things with other people, again, that's an option. And if you're a coach then yourself and you want to, get a bit more education, we do have an education platform called the Coach's Corner, which you can subscribe to. And we're releasing more content in there all the time that's relevant to personal trainers and people interested in their training and nutrition. So get involved there. We have this podcast, as you know, so I'd recommend that if you enjoyed this podcast episode or another episode, do share it on your Instagram story or wherever you happen to use your social media. And if you can leave a rating and review, depending on the platform that you use, that would be fantastic. We would be very grateful. I think that's everything we do, is it?
I believe so. I believe it is, Gary. Well, it's not everything we do. Like, we do also have lives, but that's everything we're asking people to do for us.
I don't have a life, but yeah, absolutely.
Anyway, that is the podcast. I hope you enjoyed it, guys, and we will see you on the next one.